Good afternoon, everyone, and thank you for joining us for the February installment of the School of Nursing's Nursing Education Connection webinar series. I'm Brenna Klink. I'm the event coordinator here at the School of Nursing. The Nursing Education Connection series is meant to keep you, our supporters, connected to the pulse of the work and accomplishments of our faculty, students, and staff. We are incredibly grateful for all you do to support the School of Nursing. We do have a few housekeeping items before we introduce our speaker. We would like your participation during this webinar, so we invite your questions and comments. If you think of a question for the speaker at any time, please type it in the Q&A section, and we will answer as many as we can at the end of the presentation. During this afternoon's webinar, we will also be sharing relevant links with you in the chat box, which can be viewed by clicking chat along the bottom of the screen. If you're interested in supporting innovation efforts at the School of Nursing, we ask that you consider donating to the Arlene McGrath Fontaine Memorial Fund. A link to that fund is in the chat, and we will share the link again at the end of the webinar. Now, without further ado, this afternoon we are pleased to welcome Dr. Julia Seng. Dr. Seng's research focuses on the effects of post-traumatic stress disorder on women's health and childbearing. Her projects have approached this topic from a variety of perspectives. She used qualitative participatory action research to understand women's experiences and to inform intervention development. She has used large data sets to see how PTSD is associated with pregnancy complications and worse physical health across the lifespan for women. Clinical studies have examined neuroendocrine pathways that link PTSD to preterm birth, lower birth weight, and pregnancy complications. Today, Julia is going to focus on how the research led to spinning off a nonprofit organization from U of M, which she says is like going to school all over again to learn how to be a CEO. Dr. Seng, thank you so much for joining us today.
Thank you. It's my pleasure to be here. I appreciate the invitation and the chance to get to tell this story. And I want to say hello too, because for those of you who've come to hear, we really appreciate you being here. And the audience includes some former students and colleagues. And so I'm really happy to know that you're there too. Some of this story will be really familiar because some of you walked through it with me at your time when we were working together. So without further ado, I'm going to go ahead and launch into the story and look forward to questions and answers afterwards. So I hope that you'll be thinking of things that you'd like to know. We should have about 10 minutes at the end. Okay, so hopefully you can see my slides here. And basically, what I'm going to focus on is the journey to impact that I've been on with my colleagues and students for this time, and that I'm on with staff members now. So the overview of the story I'm going to tell is how I came to my research questions way back when, a little bit that we learned during my time as a traditional academic researcher, and then also about a period of time when things got tough. And I was stubborn for a while, and then eventually kind of accepted that there might be a better path to follow. And I became what I do still call a reluctant CEO, and looking at how we moved forward and what impact we're still striving for, but from a different standpoint now. So how did I come to my research questions? Well, I do have a lot of alphabet soup behind my name because nursing is a second career for me. I started out as a high school teacher and a department chair, and it only took me about 3 years to realize that 30 teenagers against one teacher alone in a classroom was bad odds for me. So I did really love working with young people, but I liked them better one-to-one. So I decided to become a midwife, and there have been times during my career where I've still gotten to work with teenagers. So it's been like the best of both worlds to be a clinician working with students at times. So I did a second career BSN. I have my BSN from George Mason University in Virginia. And then the University of Michigan School of Nursing opened the midwifery program, and I joined in the second cohort back in 1992. And during my studies, I worked on a master's thesis, which we did back then, and I really got bitten by the statistics bug and was really interested in becoming an academic. So I went out and practiced for a little while, but came back and joined the PhD program in the women's health track that we had back then. And then I did a postdoc at the University of Iowa while I was on faculty there as an assistant professor. And that postdoc was in the School of Health, Public Health, working on outcomes research. What I could say from the beginning is that trauma was everywhere I turned. Certainly, I was a girl who had a large number of adverse childhood experiences or ACEs. And then also, as a young adult, when I was a graduate student the first time through, I had a serious cancer. And those things have always informed my research because I feel like I know trauma and traumatic stress from the inside out. But really, my questions came to me working clinically. I worked at Planned Parenthood first as a volunteer and then as a midwife, and then also in my experience as a labor and delivery nurse and working with the Seng team, I was seeing many reactions in clients that looked like more than anxiety to me. And nobody I was working with, not even the more experienced clinicians, could really answer my questions about what I was seeing. But I did have a nurse psychologist friend, and she listened and she put a name to it for me, which was really helpful. She said, I think you're seeing PTSD reactions. And of course, at that time, which was in the early 90s, there was literally nothing in the literature. There was a first person account that was shepherded into the journal Birth by Penny Simkin. A woman named Mickey Spurlick wrote an article in 1993, but it was in essentially a zine. It wasn't online, it was actually on Ditto paper. Diane Bone was a midwife who wrote about it for the first time in the Journal of Midwifery back in 1994. And then I wrote my first paper, which was a student paper that I turned into a publication in 1995. So very, very little to go on at that time. What I was seeing in my practice at that time was experiences from early adolescents who I was caring for in an interprofessional program through the Toledo Public Schools. And then also as a midwife at the Toledo Hospital, we had a very small private practice where most of the women who were choosing us and finding us were coming from traumatic first births, and they were hoping to have a different experience with a second birth. And I was also observing fairly frequently really anxious reactions to physical examination. So once I had that term PTSD, I felt like I was seeing it everywhere, but that not everyone had a lens to look through where that would be evident to them. So this informed my research program as I started off as an assistant professor. And basically, back during this time period, research question number one for me was, is pregnancy complicated if there is a PTSD diagnosis? And there was almost no way to answer this question except to look at claims data. So I studied Michigan Medicaid data to try and answer this question. The context here that's really important is that it was only in 1993 that we even had documented evidence that women got post-traumatic stress disorder. An epidemiological study done by the National Crime Victim Center showed that women did get PTSD, and in fact, they got it at twice the rate of men. And then in 1995, the first major national PTSD study came out from U of M. It was done at ISR, and it showed that when women get PTSD, it can actually become chronic in 40% of them. So the midwife in me was asking, well, some women thus must have it when they're pregnant, and what effect does that have? The second question that I asked was if they have it while they're pregnant, what's their experience of it? And so I did an interview study where I asked them to talk about how a history of sexual trauma might have been affecting their pregnancy experience. Because I wanted to know, am I just projecting and seeing this everywhere, or do women see it this way as well? And we started asking about sexual trauma because that seemed like the most evident potential cause for the reactions that we were seeing. That was a very special and very informative study. And then the next question was, If they have it and they're experiencing difficulties with it during their pregnancy, what do they want from maternity care providers? And so we asked very specifically about that as well. And that paper was published back in about 2002. So meanwhile, it turns out that that woman who had written the mimeographed article in 1993, Mickey Sperlich, lived in Ann Arbor. What were the odds? And so we got together and started a collaboration that we're still engaged with, almost 30 years later. We wrote a book together with our qualitative research combined, and it was honored as the American College of Nurse Midwives Book of the Year. And it was a very large undertaking, but very descriptive. It didn't really tell the clinical world what we should do. It could inform individual women and individual providers, but that's as far as that went. So the next question was, can we see clinically and biologically effects of post-traumatic stress disorder? And so we moved into the institutional settings and the clinical settings and got NIH funding for the Stacy Project, which was a 5-year prospective observational outcome study. And we got to answer a lot of research questions with this study. We asked what trauma exposures matter, and sexual trauma does matter to women's experience, but it was childhood maltreatment trauma that affected outcomes. It affected perinatal outcomes in the form of lower birth weight and shorter gestation. It affected maternal mental health. We learned that pregnancy PTSD is actually the biggest risk factor for postpartum depression. And it also affected early parenting. There were women who had intention to breastfeed, but if they had PTSD, they were less likely to meet their goals. And we also saw that women had delayed or impaired bonding if they had post-traumatic stress disorder. We really wanted to know, is it the trauma exposure itself, or is it the mental health effects of the trauma exposure that affect outcomes? And we learned that it's the mental health effects. Many women are resilient after trauma. It's the ones who aren't resilient who need our clinical attention. We also wanted to know if it's PTSD that they've had any time in their lifetime or just PTSD going on in pregnancy. And by and large, we learned that it's PTSD in pregnancy that we should be paying attention to. We also learned that there are enormous disparities. In our beloved university town, the rate of PTSD in women who are having their first baby was 4%. But in the Detroit area, combining Henry Ford and Hutzel Hospital, the rates were 14%. We also went ahead and studied the hormone cortisol, which is a stress marker. And what we saw here, looking at these lines, is that the women in the black line were women who'd had no trauma exposure, and they had the lowest levels of cortisol. The green line were the women who had had trauma, but they were resilient, and they just had slightly elevated, but not statistically significantly elevated cortisol. The women in blue were women who had PTSD, but it could be from something else, like a car accident or unexpected death of a loved one, and their hormones were not very strongly affected either. But the red line is the women who had child maltreatment history, and their post-traumatic stress disorder was sometimes complicated by dissociation as well, a marker of severe early childhood trauma. And you could see that cortisol, which is kind of a toxic hormone to the fetus, was at very, very high levels. Their levels in early pregnancy were 10 times as high at the end of their day. So, as interested as I was in cortisol, I was more interested in oxytocin because that is such a vital hormone for reproduction and for the caregiving system. Childhood maltreatment trauma, which really became our focus at that time, is considered an injury to the attachment system. And so, pediatric cascade theory tells us that this dysregulates the oxytocin system. And when oxytocin system gets dysregulated first, then when the child's HPA axis comes online at around age 5 or 6, that can be dysregulated as well. And that's what we see more in the adult trauma. So we also looked at oxytocin, and you can see the colored lines are different colors, but we saw the same type of pattern. The blue line were the women who had no trauma, no PTSD, and these were their oxytocin levels in pregnancy, where we watched them over a 24-hour period. on an inpatient unit at U Hospital. The blue line was the people who had PTSD, but no dissociation, so probably not childhood trauma or probably pretty resilient. And then women who had just dissociation but no PTSD had a slightly erratic level of oxytocin. And the women who had both dissociation and PTSD had really dysregulated levels of oxytocin. Their patterns resemble the patterns of patients who have schizophrenia, which is a condition known to have altered oxytocin. So this was really interesting to me, and it showed that, it's not really all in your head, that the trauma and maltreatment history and PTSD effects were in fact playing out in the body. So Mickey and I said, "Oh my gosh, we have to do something about this." And so we chose to make a left turn in the program of research. And this was around 2000. We didn't even wait for the final results of these studies. So I'd say this is around 2007 when we started figuring out what can we do. And this was a really important time. In 2005, the rat research came out that showed that if you could take high anxiety mother who would have high anxiety pups, and you could put her high anxiety pups with a low anxiety mother, that when those pups had babies, their pups would be low anxiety pups. And so it was really important because it showed that if you could change the maternal behavior, you could actually change the genetic expression in subsequent generations. So this was when epigenetics, the science of how those genetic changes happen, was just starting. And we were like, wow, if we could change the moms, if we could work on their PTSD in pregnancy, then maybe we could help break the cycles in these families that have psychiatric vulnerability and often have cycles of trauma, or abuse and neglect as well. So that's when I had to become a stubborn academic researcher because Mickey and I built the Survivor Moms Companion curriculum. And it focused on essentially two things: mental health literacy, so teaching about post-traumatic stress disorder. It focused on reducing stigma and self-stigma by making it very clear that this history happens to 1 in 5 women. And that's why we've gone ahead and used the term survivor moms and used the term companion so that they know they're not the only one and they're not alone. And then also, we designed it to empower women to seek further treatment because education might help them manage PTSD, but it's not enough to cure PTSD. So also, we built it on the shoulders of people who had created what's now really gold standard psychoeducation for PTSD. So we tailored it to pregnancy, but we're giving information, skills, and emotional support that is designed to help people with complex PTSD. And because of that book we'd written and all of those narratives and interviews we did, we knew that this curriculum was designed in a way that put into practice what women told us they wanted. So we started doing some observational studies and we were asking, some of the questions that you do ask at the beginning of intervention development. Is this intervention acceptable? And we had done some really inclusive and participatory processes so that we knew that quite diverse women did find it to be acceptable, and that their feedback was that it made a difference to them, that they got a lot of information, they felt that there was hope for them as a mom, and it made a really big difference that went right alongside their prenatal care journey. We also had to ask, is it safe and is it feasible to be delivered in the community and outside of clinical settings, outside of a therapist's office? And we did keep track of women's subjective units of distress or disturbance while they were working on the homework and while they were in tutoring sessions working on the 10 modules. And what you see in this graph is that they did have emotional responses to the material, but it's on a scale of 0 to 10. And the responses did not go up to a level of distress that we had to be clinically concerned about. So that showed that, it did probably fit the niche that we wanted it to, where it could be delivered by perinatal staff and not have to go to the level of being a social worker or a psychologist who was a therapist. Then we said, do the symptoms improve? If we teach women to manage their PTSD symptoms, can they get some relief from them? And what you see here is that the blue line is the women who are mostly resilient. They didn't meet criteria for having PTSD, they just had some symptoms. And you can see that across the intervention, we measured every 2 weeks, that they were experiencing a decrease in their symptoms. So hopefully those skills that they were learning were helpful. The green line is the women who did have post-traumatic stress disorder at the beginning of the intervention. And the cut point for probable PTSD in women is 31. So you can see that those women started off on average up around 50 on a scale that goes from 0 to 80. So they were quite strongly affected, and you can see that their symptoms also dropped off. So we were hoping that the support they received and the skills they gained were making a difference, and it does look like they were. The other thing, finally, that we wanted to know was that the women in their interviews and the women in that big study I told you about that took place in Ann Arbor and Detroit, those who had PTSD had had worse outcomes on several things. And we wanted to know, compared to those women, the women who got the intervention, did they have a better process and better outcomes? And from this graph, you can see that their scores were better on dissociating in labor, which is a sign of overwhelm and severe stress, how they rated their labor experience and their perception of the care that they received, and their PTSD, depression, and bonding scores were also better. So this was a good background starting out. But the next question we asked is, if social workers can deliver this in the community or nurses, people who are licensed, could we also do it with the large workforce of community health workers or doulas? And so we did another observational study in Buffalo, and what we found was the answer to that was yes, also. The women who participated in the intervention study in Buffalo actually had more severe trauma histories and PTSD. They also had moderate levels of depression. So they were actually worse off than the women in the first study. But when the community health workers delivered the intervention, they got similar response patterns. So similar size decreases in PTSD, depression, interpersonal reactivity, and anger expression, which are the main things that we measure. They also were able to deliver the program with no adverse events. So, meanwhile, while those studies were going on, we were grant writing fiends, and we have written a total of 10 federal grants to try and get funding to do a randomized clinical trial of the Survivor Mom's Companion. We applied to the National Institute of Mental Health, the National Institute of Child Health and Human Development, to HRSA's Maternal Child Health Bureau. And we had partners who were working with us on this in Australia and in Britain. And we wrote to the national health funders in both of those countries as well. Eventually, we even pooled our resources and planned a three-nation center grant for this. Every single one of these applications scored, so they were well received, but none of them ever funded. So this was challenging because professors are supposed to bring in research revenue and they're supposed to have an impact. And we were not being successful at either one of those things. So we thought about it long and hard, and we made the decision to go ahead and spin off a nonprofit company from the university. And we got help from the school's Health Innovation Impact Program, and also from the university's Office of Tech Transfer, which is now known as Innovation Partnerships. So I consider this phase of my life that I'm in now the reluctant CEO phase. You may not know that about 30 companies a year are spun off from the university because the university owns the intellectual property when professors create inventions out of their program of research. So, right now, we have an 8-year license from the university to use our intellectual property, and the 501(c)(3) that we started holds that license now. And if we make good on our license agreement, then the university will transfer our intellectual property back to us in 2028. So we're working on it. Here is a shot of our organization's website. Our nonprofit is called Growing Forward Together. We wanted to call it Growing Forward. That's a name that came to us out of a qualitative study that one of our graduate students did for us. And Liz Mosley did that study because the term survivor mom just was not flying in Australia. And so she did a study with nurses, midwives, and obstetricians in Australia, Britain, and the US and asked for suggestions. What should we call this program? They said Growing Forward would be a great name, but when we went to start our company, Growing Forward was taken. So we had to go with Growing Forward Together. We also tried to get GFT because it's a lot shorter, but that domain, which is still for sale, costs $24,000. So we haven't sprung for that yet. We just type a lot when we write our email addresses and go for our website. So what you see is that our nonprofit is like an education hub for trauma-specific education. So that's the high-level education programming that is for people who can self-identify that they're survivors and they want more information about their condition. And it's also helpful for providers where they've already kind of had the Trauma 101, but they want to know how to change their practice and how to address trauma more competently and more comprehensively in the work that they do. So currently, the nonprofit has 3 programs. It has the Survivor Moms Companion, and that's our flagship program. That's what we're really putting all of our effort into right now. Trauma and Society is another program that was developed by my daughter, who is a high school teacher, and me. And it's kind of backburnered at the minute, but we're looking forward to getting that going. It's built on the same theory of change as the Survivor Moms Companion, but it's made for high school juniors and seniors and emerging adults. And then we get asked a lot to do professional development. So we also have a program that provides education for providers. So we have a lot of work to do. We're filling an important niche at that advanced trauma education level. So as I said, our mission is to create and advance trauma-specific education programs for emerging adults, childbearing and parenting families, and their providers. And our vision is something that we hold really strongly to. It's to equip people to build a world in which trauma history, gender, and race are no longer predictors of health or social outcomes. And that's our North Star. I do have to say, though, that starting a nonprofit was like being a graduate student all over again. I had to let go of a lot of the competencies that a professor builds over time. I had to accept that there was going to be a really big learning curve. But I'm happy to say that we started in December of 2020. So really, in 2021. And so we've completed our first 4 years and we have seen growth, which is encouraging. It's not as fast as we would like it to be, but I'm learning to take leadership of a really great staff, small but mighty. And we still provide lots of learning opportunities for students across many disciplines, from public policy to nursing, social work, education. And also, we are able to try and fund some younger interns every summer. So it's really the human beings, and they come and go sometimes, but it's been a wonderful experience to have staff to lead. And you can see that we are growing. Our org chart, which is already out of date, it's like out of date every 2 months, I think, shows that we look like we have a lot of people. In reality, we have a wonderful board and we use a lot of contractors and consultants, people who care about our mission and bring their talents, but they're able to work, at 10 to 20% of a full-time effort. So there are few of us who are actually working here full time. And even I don't work full time. I'm in phased retirement from the university. So I'm 50% professor and 50% CEO at this point. And over the 4 years, we've also had financial growth, which is a marker truly for productivity more than anything else. We manage to just barely live off of what we bring in, but we are getting more that we can do every year. So, as I've said, the three programs are like jet planes to us. Survivor Moms is now kind of gunning its engine, ready to take off the brake and take off. The professional development program, we think of it as, kind of taxiing to the runway. We've just been able to buy Canvas as our learning management system. So we're loading up some education programs and getting ready to start marketing those. And then Trauma and Society is at the gate. I think it's, loading the food and the luggage and the passengers at this point and getting ready to take off. We're just getting ready to start going after some funding for that. But right now, Trauma and Society is running on a gift and doing small demonstration projects. And then we also have a contract with the state of Iowa. So we're able to do some demonstration projects there as well. And so basically, at this point, when I stand back and look at it, I can see that we are managing to get survivor moms to move forward with a lot of support. And it has taken nimbleness and flexibility. And these are things that we have in the nonprofit sector that we don't have at the university. When we start something and we expect it to work and it falls apart, we just pivot and kind of keep going. So we started out as an agency model where we would sell Survivor Moms licenses and train a staff to deliver it to their own clients. And what we found about that was only affluent agencies were able to sustain it. So it was sustained in Ithaca, New York, Grand Rapids, Michigan, Oakland County, Michigan, but other places that tried it, like they would train someone and then that person would leave and they couldn't afford to train another person. So we were starting places up and then losing them. So we decided to pivot to a solo practitioner model where we would focus on training the tutor to deliver the program and support them to do that. But what we found is that they wanted to do it and they could see the usefulness of it, but they couldn't find a way to get clients and to sustain themselves doing it. So now we're on what I hope will be the last pivot, but I won't say that. It's a referral model. And what you're seeing in the picture here is that we have an online directory to help women find your tutor. And we're now training hospitals and community-based organizations to refer to the Find Your Tutor platform so that their clients can shop for a tutor online and match up with someone that they would like to work with. So basically, we're not doing anything directly with the clients ourselves, but we're training the workforce to deliver Survivor Moms, and we're training the community-based organizations and hospitals and clinical settings to refer women with a QR code to this directory so that they can explore. We also started out using books, and our original benefactor, who started us off with philanthropy, was a publisher. And so our books are beautiful, but it turns out that, it's a logistic problem, especially post-pandemic, to get books to people when the intervention might be delivered virtually or when the people are living in very high stress circumstances and it's hard for them to hold on to a book or it's hard for them to find time to read it. So we have benefited lately by further grant funding to get Canvas and catalog so that tutors can each have their own course in here that we load up for them, and they can meet their clients online and enroll them in Canvas and deliver it via Zoom. We also did start with an awareness of health disparities, but things have really moved on in the past few years. Not fast enough, but to where we really needed to deal with the fact that trauma isn't the only thing that many clients are dealing with, that they may also be experiencing discrimination, microaggressions, or minority stress. And so our current leadership is with African American women who have helped us go to the next level in terms of bringing true diversity and a move to move the needle on equity into our programming. So we're just completing a series of videos that are presented by diverse tutors in English, and they summarize each of the modules. And then we also have a series that's being delivered in Spanish, and we have an audio component that's in Arabic, which is really important in our region as well. So, what impact are we having? Well, it is coming full circle right now that despite those 10 applications that we did not succeed at, research is beginning to be underway. In the state of Indiana, their psychiatric consulting service is going to be starting to offer survivor moms to women with opioid use disorder and other substance use disorders, and they're going to be studying how that goes. There's a researcher at the National Center for PTSD who has put in an R01 type grant to do a clinical trial of SMC with women veterans who are in touch with maternity care coordinators. And that will be done with clients who could be anywhere in the United States, and it will be delivered by telehealth by peer support workforce. So women who have themselves been through treatment for PTSD. And so we're very excited about that. The National Center for PTSD is known for truly outstanding research. And so our partner there is amazing, and it will take time, but we're looking forward to that. And the impetus for doing that study is that the VA wants to take up survivor moms for pregnant and parenting veterans. And then it's also, there's a grant under review in Berlin, and if it's funded, it will involve translating SMC to German. But there's a very large midwifery workforce in Germany, and they want to train midwives to deliver SMC to their clients. And they're also going to do some biological stress-based research if they get that grant. And then I'm very happy to say that Mickey Spurlick, the co-developer, has received an NIH Improve Initiative Prize to do an RCT, continuing the work with the community health workers in Buffalo. It's kind of like trying to do an RCT on bake sale money because it's only $200,000. But she's doing it. So we're very excited that the research is finally happening. We also have had grant funding that is or has helped us with many things, including capacity building, piloting some use of SMC training as professional development, piloting our referral workshops, and looking at ways to get Medicaid involved in sustaining us, starting in the Upper Peninsula. And then we're hoping to also do more work in the city of Detroit on a SAMHSA-funded grant to the it's very hard to say, Merrill Palmer Skillman Institute at Wayne State University. And we've also had support for things like making videos from the United Way locally. And finally, we're getting some grant support this year, some money that has to be spent very quickly, that the state is putting into the perinatal quality collaboratives. And we're going to be able to train teams of doulas in Region 1 and Region 5 and Region 8. And we trained in Region 9 last year. So we're very excited to finally have a model up and running that we think will work, especially if the tutors can come together at the region level and have meetings to sort of get technical assistance, to share case stories and get reflective supervision. And that we hope they'll form really good relationships with the community organizations and the hospitals that will refer clients to them. So if there's anything you can do for us right now, it's to cross your fingers and talk it up in your place in the state if you're watching from Michigan. So we also are trying to conquer sustainability by getting Medicaid to pay a little bit of money for each client who does the Survivor Moms program. We're asking for a single payment that will help us cover the costs of Canvas and some of the curriculum development and sustainability costs that we have. So this is an example of, me being back at being a graduate student. There's so much alphabet soup. If people had told me I needed to talk to the MCOs and get an APM, I'd have been like, what? So I'm learning, and I'm now a member of the Medicaid Health Plans of America professional association instead of, so many nursing and mental health ones. But it's been really interesting, and it's important to know that, we aren't the only program in the world that's challenged, that a lot of people are trying to get resources to do amazing things and change things for childbearing families. So I do want to give a shout out to HIP and to Innovation Partners, and also to Ann Arbor Spark, which has given us really great concrete support for things like the legal cost to trademark our interventions and an entrepreneur in residence for a while. We're getting a lot of support from a lot of places, so really appreciate all of that. And I want to thank you so much for listening to this story. And I would love to take your questions and have a little bit of conversation that way.
Okay, we do have a few questions that came in. The first one, Dr. Seng, what protocol did doulas, non-licensed personnel, follow if they suspected self-harm or suicidal ideation?
That's a very good question. Anyone who becomes an SMC tutor, in addition to the training, they have to sign off on certain commitments that they're going to make as a tutor. One of the commitments is that they can never just give the materials to a client without tutoring them. That's like a real bottom line thing for us. The other thing is that they must have a relationship with a mental health care provider who will take referrals for them or who will consult with them. And they must have two referral resource lists. We give them a referral resource list of national resources, but they must also cultivate one within the regions. And actually, that's one of the reasons why we're trying to organize them at the region level so that each doula doesn't have to do this for herself, but that it can be done once by a leader in the region, and then it can just be updated as things come along. The other thing that's super important is that the end of our training, there are pre-learnings and then the training workshops themselves, which have simulations as part of them to demonstrate competency. But then the training continues for another 8 months afterwards, where they're in a community of practice where they can get technical assistance and reflective supervision and keep learning, because there's lots of things that doulas come in many forms. Many of them have quite a bit of background, but others are brand new, and they may not come from college education. They may not have ever been in healthcare. So the community of practice is a place where there can be guest speakers and other things that help bring them up to speed on these issues. So we spend time talking about things like what are the therapies for PTSD? How do you consult a psychiatrist if you need to call the state psychiatry consulting line? And, what are you asking for when you do that, basically? And lots of other things, because the trainings really teach how to deliver survivor moms, but they're not deep knowledge about trauma and PTSD itself. So we provide more space for more learning to go on.
Another one about your 501(c)(3) status. Why did you decide to go the nonprofit route? If you had to do it all over again, would you still do it that way?
Oh, that's a great question. So ignorance being what it was on my part, I didn't know about the idea of a B Corp. If I had known about that idea, I might have gone that way. But basically, the difference between for-profit and not-for-profit from the standpoint I had at the moment was that a nonprofit, I'd be needing to go after, philanthropy, grants, contracts. In for-profit, I'd be going after venture capital. And I just didn't have any experience with that world. But grants and contracts, I could learn. They weren't going to be science contracts and grants, but I still knew how to manage those. So when I thought those were the only two choices, I went towards 501(c)(3). I've since learned that a B Corp is kind of a middle ground, that in the B Corp, you have stakeholders that you're responsible to. So that would be like ultimately the clients, the providers, the tutors. But you also have shareholders that you are responsible to. And that's a way that you can get venture capital and seed funding and other things. And you are serving two groups there, but it seems like there could be synergies. So that might have been something that if I knew now what I knew then, I would have tried. But we're okay where we are right now.
All right, let's see. I like this one. How will you know if you've been successful?
Oh, well, I think my answer to that is twofold. At the organization standpoint, I think we'll know we're successful if we finally create models where many people are getting tutoring and are getting the intervention. So, right now, our focus is on the tutors, and we kind of don't have bandwidth to learn about the client experience, but we would like to get enough tutoring going on that there are resources so that our evaluation folks can reach out and learn more about how it's actually working on the ground, and to learn that it's going well, to do QI if it's not, and we need to tweak things, but to be able to continue to scale it up. We're in contact with some mentors who are in the for-profit world, but they've been doing social entrepreneurship and have also had kind of a long path to sustainability, but then they've hit an inflection point and they've really been able to grow. And that's what we would like to do with this. Personally, I would like to grow the organization to where there's a program director for survivor moms, the adolescent program, and the professional development, and where we have specialists. We have an evaluation officer and we have a financial officer, so that basically I can just become president of the board and I don't need to be the CEO anymore. That would be my idea of organizational success at this point. It could happen.
Wonderful. Well, thank you so much for taking the time to connect with all of us today. And thank you to everyone who has joined us. Once again, if you would like to make a contribution to support innovation efforts at the School of Nursing, we ask that you consider donating to the Arlene McGrath Fontaine Memorial Fund. You will find a link to do so in the chat box. Please feel free to contact Dr. Seng as well with any questions, or reach out to Beth Nugent from Development at any time to inquire about supporting our work. You will find their contact information as well in the chat box, where you'll also find my email should you have any questions about alumni-related activities. In the coming days, we'll be sending a follow-up email that will include a brief survey about your experience during today's webinar. Your feedback will help us in planning our future webinars, so please share topics you'd like to hear about, and please be candid. We really do appreciate all of your thoughts and comments. We hope you will join us for next month's Nursing Education Connection webinar with Dr. Yasmin Kuzanoki, who will be discussing partner violence and sexual health. Details and registration will arrive in your inbox soon. Again, thank you everyone for joining us today, and have a wonderful afternoon.
Thank you.